I'd like to introduce our next speaker. Dr. Paul Rubin, DDS, is a master in the Academy of Oral Medicine and Toxicology. He's been a member almost since the group's inception. For the most of that time, he's been a member of the board of directors. He's held many committee chair positions and has served in many offices through the years. He's been awarded both the fellow and master with IAOMT and has successfully published research on environmental effects of mercury. He's a co-founder of New Directions Dentistry, and Dr. Paul currently practices in Seattle, Washington. Welcome, Dr. Paul.
Thank you. Thanks. How's the microphone? Are we on? Yeah, we're on. Okay. I almost hesitate to say this. I may be getting in deep here, but I'm also trained with the biomodulator. For you guys who are here for Dr. Tennant's thing, if anybody wants to catch me anytime later during the weekend and wants to get their bowling ball fixed, I'll be happy to do that. So I'd like to just get a sense of where people are, how many already use cone beam images, either have one or have access to using them, and how many are unfamiliar with or not comfortable with looking at, reading, and manipulating through a cone beam image. Yeah. Okay. How many never raise their hand in public? Okay. Let's see. Let me make sure I'm not missing a slide. So this is me. If you want to get in touch with me, email is best. And again, of course, all these slides will be available, on the website. So we've gone through an evolution in imaging for dentistry. We've had, of course, intraoral X-rays for a long time. The next sort of step up from that was panoramic X-rays. Digital came along, giving us a lot more abilities of manipulating images, lowering dose, and so forth. And this sort of the next step in diagnostic imaging for dentistry is the cone beam X-ray. CBCT stands for cone beam computerized tomography. Some people just call it cone beam. Some people call it a 3D pano. So why use this? And I think the bottom line really comes to this. More information equals better diagnosis, equals better dentistry and better service to our patients. And that's kind of what I think should be the driving force, not that it's going to be a profit center or this or that, but better treatment for our patients. So I want to give a little contrast between cone beam image and medical CAT scans. This is an image of a medical CAT scan. There's a lot of differences that we should know about. I just lost audio here. Am I on? Okay. Maybe I just lost echo. Conventional CAT scan is a fan beam, as you saw on the image here. It goes through multiple revolutions taking the scan. It's mostly used for soft tissue detail. It's a much higher cost and a much higher dose than a cone beam image. Cone beam has a very narrow focus of its beam. It doesn't scatter throughout the rest of to the rest of the body. It's very focused. There's a single revolution. It's mostly for hard tissue, although you will see you're going to get a lot of soft tissue information there as well. Much lower cost and a much lower dose. When we look at applications for cone beam imaging, there are many, and I'll list these in no particular order. Looking at developmental abnormalities, implant imaging and treatment planning, orthodontics, airway space evaluation, pathological findings, trauma, the relationship between teeth, especially third molars, and the mandibular canal, TMJ imaging, periapical and periodontal findings, and bone cavitations. Dr. Pierre LaRose just sent me this last week. The recent issue of Gordon Christensen's clinician report had a whole issue on cone beam, and he says every clinician should at least have access to cone beam, either by purchase or by referral. It's a good article if you get his clinician's report, or if you can get hold of this one. It goes into a lot of detail about cone beam and comparing different brands, etc. Today, my focus is going to be on recognizing and identifying abnormalities on the image that you wouldn't see on other dental x-rays. And we'll look at things that you might see on other dental x-rays, but you'll see very differently on a cone beam x-ray. We need to address the question of exposure, because your patients will ask that. And I think those of us doing biological dentistry, we have more patients asking more questions about x-ray dosage than most practices do. So I had a hard time finding good, reliable, objective information about dosage with cone beam x-rays, except for what the manufacturers tell us. So I'm basically relying a lot on what they're saying. Dosage is measured in microsieverts, and the best way to get a sense of what is a cone beam exposure like is to compare it to other x-ray imaging. In our office, I practice in the space with Dr. Mitch Martyr. I think you're back there. This is his unit. It's a Galileos by Sirona. I forgot to read the card in the beginning, but I have no financial interest in this product or any other. This is the unit that I'm familiar with. There's other brands that are going to be fairly similar, but the kind of images I'll show you today are mostly from a Galileos image. One scan is about 70 microsieverts. That compares to other x-rays. It's about 3 to 4 panoramic radiographs, whether it's film or digital. It's about 1/6 of a film-based full-mouth x-ray. It's slightly less than a full-mouth digital x-ray. And it's equivalent to about 8 days of just walking around in the earth background radiation. We always have to be concerned about exposure, weigh exposure versus the benefits we're going to get from exposing the patients, and you have to be able to feel comfortable yourselves in what this means to you so you can feel comfortable explaining to your patients. Here's a chart from Sirona showing on the right their dental x-rays in general are very, very low compared to medical x-rays. The Galileos, I said, is 70 microsieverts. If you compare that to a head CAT scan, it's about 2,000 microsieverts. So let's put that part behind us. So what does a cone beam image look like? Let's go ahead and look at one here. This is what the image is going to look like when it comes up on the screen. Now, if you have your own unit, you're going to have software that will bring this up. If you are referring out to get a cone beam image taken somewhere else, you're going to get the image on a CD disk that plugs into your computer. It's embedded with the program that you need to bring this up on the screen and navigate through it. So on the upper left part, you'll see here's a more or less panoramic view. Now you can print this out as a flat panoramic and put it into your chart, into your dental software. On the upper right, you actually see this is the information that's on this scan in 3 dimensions. You can kind of play with it. I'll go through manipulating through here a little bit later, but this is just the kind of things that you'll see. On the lower left-hand side is a tangential view, as if you're looking straight on at the patient. And on the middle lower there, you're looking at a cross-sectional view of the same spot that you're looking at on the tangential view. And on the lower right, you're looking at an axial view as if looked from above and at the same plane, at the same spot that these other views are. On this panoramic view, you'll see a little square that says slicing window. This will move any place you want on the image, and you're looking at a narrow piece of this image showing on the screens below. There's another mode to this. This is called the panorama mode. If we click on the radiology mode, you're going to see some different kinds of views. Look on the upper right hand, and you'll see 3 planes. You can scan this image in all 3 of those planes and basically look at different slices. Upper left, you're seeing an axial slice as if you're looking from above. Lower left, you're seeing a coronal view as if looking from the front. And on the lower right-hand side, you're looking at a sagittal view as if looking from the patient's right. So this is basically what an image looks like. So what are we looking for on an image? It really helps to review head and neck anatomy, especially osseous anatomy. So it also helps if you have a skull from back in dental school days or a replica skull. It helped me to have a skull side by side with images that I was looking at and get a sense of, where is this really on a 3-dimensional skull? It just helped embed the information better in my brain. We're looking for variations from the normal, so you have to have a sort of a sense of, well, what should normal look like? So for me, I had to sort of go back and relearn some things. One big help as you're looking at an image and looking through different slices of the image is looking for symmetry or looking for places where there is an asymmetry. It helps you sort of zero in on, okay, why does this look different than I think it should look? I want you to realize that this is a very, very brief overview here. To really get good at understanding how to look at these images, you really need to take a full-blown course. Sirona offers a 2-day course in this. There's other companies that offer a fairly thorough course in the radiology of looking at and interpreting x-rays, and I think this is something that if you're getting into reading these images, you really should invest the time and effort in doing. I just heard today that in Ottawa, you can't have your own cone beam x-ray image. You're not allowed to as a dentist, allegedly because it's going to show a lot more information on there than dental, and you don't have the training of how to understand that image. You can use a cone beam if you send it off to somebody else, but you can't have one in your office. We'll touch on this a little bit more about the fact that you're going to see more than a dentist usually is going to see. So let's go back and just kind of navigate through an image and see how this works. When I'm looking at an image, I tend to start with this radiology view, which lets me look at kind of the whole skull. If I go up to this view and start going up and down on my mouse, can you see on the upper right how that plane is going up and down? That orange plane. So this, when I'm looking at this upper left view, I'm scanning down as from above, looking at what they would call an axial view. You get the concept there? Now we can make this larger. And again, scan through here, and you start seeing things like the sinuses. You keep going down, and we'll start running into where the maxilla is, etc. You're starting to see the airway here, the mandible, etc., and on down. So you're going to want to scan through that whole image, really looking at the whole skull and not just the teeth, and looking for abnormalities, looking for things that look different than they should. You can see the same image where we are exactly here on this image on the upper left is also showing down here in the coronal view, etc., and the sagittal view. So you have different ways of looking at this image. And we can, again, on this coronal view, look as if we're going from front to back, scanning through slices this way. On the sagittal view, we can scan through slices this way. If we go back to the panorama view, this is probably one that gets used more. We're using this slicing window to look at specific smaller areas that we want to investigate. For example, on this patient, there was a question of this upper left molar, number 14, is there a problem with this root canal? A periapical view didn't really show that well. If we slide this slicing window over this tooth, now we can look down on this view and look at slices in and out and get a little better sense of what's going on here. So I'm going to enlarge this window. And as we go in and out, we can start seeing different things. Here's that root canal. One thing that I am noticing here, and you would have seen it on the radiology view also, the lining of her left maxillary sinus is thickened. And I'll have to show you what a normal one looks like, but this area right here shouldn't be there. It should be just a thin plate of bone, but you're seeing a thickened membrane in the sinus, which is indicating inflammation or infection there. If we look closer at a little bit different views, now we're going to see, I'll point over here, but look at the, actually, I'm too sideways to be able to see where this is, but can you see my little arrow? Okay. See the little radiolucency there? It's pretty evident here. It wasn't very evident on the periapical view or on a panoramic view. Now we can look at where this same spot is on this cross-sectional view. Again, navigating in and out of this. See if I can find where that shows up the best. Here, I believe this is the same spot we were looking at in the other film. So to me, this is clearly showing this is a failed root canal. I am amazed when we look at these films how many, and when I say failed root canal, you know I mean radiographically failing. As far as I'm concerned, all root canals are, failures, but that's a whole other philosophical thing. But radiographically interpreting this, it's clearly radiographically failing. I know that some endodontists may look at this and say, oh, that's just a little bit of scarring. And again, this is not a radiographic interpretation, but a philosophic interpretation of that space, I would say. I don't consider that scarring. I consider that failure, and it's probably infected. On this, yes?
I'm going to interrupt, but I have the same machine as you. Let's say that you did this scan like I did as well, and you find one that's rock solid, every dimension. What do you say then?
So the question was, what if I look at an image and we see a root canal that just looks rock solid, the bone looks just perfectly fine all around it? What do I say to my patients there? I tell them radiographically it looks fine, but here are some other reasons why root canals that may look perfect on an x-ray may not be so perfect. And I run through the whole rigmarole of what we know about root canals. So to me, there's sort of two levels. There's a real obvious level of a radiographic failure, and then there's the fact of, it's a dead tooth and all the issues surrounding that. So I won't get more into that. I'm just surprised at how many clearly radiographic failures I'm seeing on these images that I never saw on panoramic or periapical images. You can use this slicing window again to look at the TMJ and navigate through there, and you can look at the joint space, and you can look at it in different, different dimensions. Tangential, cross-sectional, axial, and see what does the bone look like, what does the joint space look like. You can look at any place along here. You can look at, of course, the bone where the third molars were extracted. And this is one of the best ways, I think, to look at and evaluate the bone for potential cavitation areas. You can look at the trabecula of the bone in 3 different kinds of views and get a much better 3-dimensional sense what's going on with that bone to be able to advise the patient, is this a likely cavitation? Again, can you diagnose cavitational osteonecrosis by an x-ray only? You may be It may be a matter of semantics. That may not be quite fair. What you're seeing is radiographic abnormality. I think that's kind of all we need to look at here. Let me go back to this radiology image again. On this patient, when I was looking at that root canal, which is the main reason we were doing this on here, and we looked through this image here from an axial view. Let me make this larger, and we'll start to scan down here. His eyeballs were picking up ethmoid sinuses. When I started looking at this the second time around, I didn't see it the first time, I saw this. This looks radiopaque. Doesn't look the same on the other side. Doesn't look like what I think the ethmoid sinus area should look like. What is that? So we can look at that in different dimensions here too. And I didn't know what that was. I got out my skull, tried to figure out where it was, and then tried to figure out what it was. But we'll get back to that again. But this is the kind of thing that you can pick up when you're looking closely at your scans. Let's go back at looking at abnormalities. So I'm going to run through some of the kinds of abnormalities that you're going to see looking on these scans. Calcified lymph nodes. The images you see here look like they're mostly from a panoramic X-ray, except for maybe the one on the right. No, this looks like it's from a panoramic. But when you see something that's a calcification here, with the cone beam now you can look at it in 3 dimensions and find out exactly where that is. You don't know where in 3 dimensions this is. Is it outside the mandible? Is it inside the mandible? Once you see where it is, you can get a better sense of what it is, and this one turns out to be a calcified lymph node. Cyaloliths, again, another calcification. By looking at it in 3 dimensions, can't see it as well here, but on this is another type of view you can get on the image, and you can rotate this skull in a bunch of different ways and see just where this this cyalolith is, which I think if I'm pointing correctly, it's here. I can't point that well from being so sideways here. But on the bottom, you can see the different different views, axial, tangential, etc., to see where that was. Tonsilloliths are apparently fairly common, and you'll see them on an image, and you can tell where they are, so you know it's in the tonsils. And here's another example of looking at a panoramic X-ray, again on upper left molar. This looks kind of suspicious on this panoramic view, but a little hard to interpret. If we look at this on a 3-dimensional view, now you can see this is an axial view from above at a certain slice, and you can see where this has been sliced. All of that is radiopaque around those root tips. On the upper right-hand view, very clear to see the defect in the bone here, and also clear to see very pronounced thickening of the sinus membrane here. You wouldn't have seen that on a panoramic, and you'll see this pretty typically next to a failing root canal tooth, that something is being affected in the sinuses there. And if you're wanting to take this tooth out and do surgery here, you sure want to know where this is 3-dimensionally and where that sinus wall is and where you're headed, so you have a roadmap before you jump in there. I used to hear about how you could pick up a calcified carotid artery on a panoramic view. I've never seen one yet. I keep looking for them. On a 3D view here, you'll be able to see it in different dimensions. So if you're looking from above, think of that as a hose going straight at you, and you're going to see it in a ring shape. And if we're looking on this view, you're going to see the, get my little arrow down here, this is the carotid artery going this way, and you can see that the walls of that artery are starting to be calcified. These are going to show up at the level of about T3 to T4. And again, because you can see it 3-dimensionally, if you see something that looks a little bit funny, a little bit radiopaque, zoom in on it, figure out where that is, and you'll be able to tell that this is a calcified carotid atheroma. Here's an example of looking at an axial view of the sinuses. the right sinus looks, on the right side of the screen, the patient's left sinus looks normal. And again, look at the wall of the sinus here. It's thin. You don't see that thickened membrane. This is pretty normal. This is all filled with junk. Fluid, snot, whatever you want to call it. It's an infected sinus, more like an acute sinus infection going on. This is probably something that would resolve itself without much treatment. Here's a view, if you look closely at number 8, this looked like there was probably some kind of a resorption going on the root of, number 9, or the U.S. number 9. In Canada, what do you call this? Okay. So some radiolucencies there. When we look at it on the axial view, now it becomes real evident. This is a big, wide internal resorption going on. Much clearer to see what's going on. If we look at a cross-sectional view, you can see the shape of that resorption. You can also see that the buccal plate of bone here is gone in this area. So a whole lot more information when you can see things in 3 dimensions rather than looking at simply a 2-dimensional image. This is a patient whose dentist took this periapical and said, 14's got an abscess, you need to do a root canal. It certainly does look suspicious. You see some radiolucency there. On a cone beam image, again, you can look at this in much greater detail. Now you can see this massive amount of bone destruction here and how it has also affected the wall of the sinus here. When this tooth gets extracted, there's likely to be an opening into the sinus here that needs to be dealt with. You probably want to know that before you go in there surgically. So a much more useful bit of information here. So here's an interesting patient that had orthognathic surgery when she was a lot younger. She's still a fairly young woman here, and she's having pain symptoms on number 31, which when we look closely at it, it's a little hard to see through the metal plates here, but there is some periapical pathology. She absolutely did not want a root canal. She wanted that tooth taken out. I think if you're going to go in there and take that out, you might want to know where are these plates exactly. So this is just one of the cross-sectional views that shows, here's part of the root of that tooth. Here's the plate. It's all on the buccal bone. You can see how far in that screw goes. You can see the mandibular canal. A lot safer surgical planning when you can see this kind of information. Here's a patient that's a mess. A lot of stuff. I've got to the point where when I see an image like this, I know this patient cannot possibly be healthy. Something's got to be really going on with their health, and it is in this patient's case. We'll just take a look at the upper left here on these bicuspids, because it looked like something was going on here. Again, when we get the scan and we look at different slices, we can get that to slice to the point where now it's really easy to see this radiolucency on the apex of this bicuspid. You also can see a little bit of thickening of the sinus membrane here. When we look at a different dimension, we can see that radiolucency is mostly to the lingual of that apex, but pretty clearly diagnostic, and no question about this. On this same patient, when we did the scan on the radiology view, remember I showed you that different kind of view? Here's what we saw in her sinus. On her right maxillary sinus, there's this nice little round thing that looks like a balloon here. This is a typical look of a sinus polyp. Another thing you can do on these images is measure this. So you have information that you can measure. You can send this information if you wanted to refer her to an ENT doctor. Here's that same sinus polyp on the 2 other views, the coronal view and the sagittal view. And on this software, you can capture this screenshot, email this off to an ENT doctor with a report, and have them have that information. You can also take the entire image onto a disk and mail that. You can't email the whole volume, it's called. You can't email the whole manipulatable image. There's just too much information. You can do a two-dimensional screenshot, email that, mail a disk that has the whole shebang in there, and they've got all the information that they need. What was this? Oh, yes. So this one, this central incisor, one dentist looked at this and said, wow, there's this big radiolucent area here next to this root canal. This is clearly a failing root canal, and this is so well defined it's probably a cyst, and was ready to go in and remove this tooth and the cyst. When we look at the cone beam image, well, here's the panoramic from the cone beam image. The cone beam image is always going to give you a panoramic view as well. This doesn't look quite as easy to interpret. But if we start looking at slices, now what we see, and again, I can't go through this live, but as we go in and out of the images here, this radiolucent area becomes much more clear now. This is the incisive foramen. And if we look at it from this view, big, wide open incisive foramen here. And that's what was showing up and sort of overlaid next to the root of that tooth, which looked like on the periapical view as a failing root canal and cyst. Back to the case I showed you before where this radiopaque area showed up in the ethmoid sinus area. Again, I measured it. You can look at it in all the different dimensions. Send this off to someone who can interpret this. One of the values of there are services who can read these images for you. Radiologists. If you don't feel you know enough about all of the structures to be able to give a thorough reading of the entire image, not just the teeth, you can send the image off to a radiologist. Or if you see a spot like this that you don't know what this specific thing is, you can send this off. There's a service called Beam Readers is one of them. There are others out there. And you send them the images, you send them information of what you're seeing and ask them for a report, and you'll get a report back like this. And I think it costs maybe $100. I know some dentists are routinely on almost every image, sending it to a radiologist to cover themselves medical legally. But certainly if you have a question, if you don't know what's going on, you want to be able to inform the patient. So it's a little hard to read here, but down at the bottom here, what they came up with on the right ethmoid sinus, consistent with mixed cortical medullary osteoma. And their comment was that otolaryngology referral is suggested. Sinus osteomas can enlarge and become symptomatic. So now you've got something where you've got a diagnosis of what this piece is. Now you can refer this off to an ENT along with this report, along with the images, and you've done your patient a service because you saw something that would never have been seen before. It might be perfectly innocent on this patient, but it's good to know that it's there. Here's information on Beam Readers, and again, you'll have that in your notes. So implant site assessment is probably the biggest driving force in cone beam sales. This is what many, many people are primarily using cone beams for. I will tell you right now, I don't do implants myself. So I'm going to run through this real briefly. Those of you who do, you can get a sense of how valuable this can be. Panoramic images are helpful, but they're limited. They have parallax problems, and they're two-dimensional. You can't see what's going on three-dimensional. So here's some things of concern that you should be concerned about before doing an implant that you can address on a cone beam image. You can see the mandibular canal. And on the Sirona image, you can actually trace the mandibular canal and leave a highlighted red line, trail, where that mandibular canal is. So in every view that you look at, that's just going to stick out you like a sore thumb, and you can know exactly where that canal is three-dimensionally. You can see where the maxillary sinuses are, where the incisive canal is. The submandibular fossa, something that a lot of people don't quite grasp until they start looking at this three-dimensionally. I'll show you a drawing about this. Facial bones in the anterior region. The American Academy of Oral and Maxillofacial Radiology recommends that cross-sectional images be used for the assessment of all dental implant sites, and that cone beam is the imaging method of choice for gaining this information. So really, for implant planning and implant placement, this is now state of the art. And if you're not looking three-dimensionally at images, you may be in a bit of trouble. Here's what they talked about as in terms of the submandibular fossa. If you look at this on a panoramic image from this dimension, looks like there's lots of bone here. Stick an implant in there, no problem. But here's this concave area that doesn't show up on the two-dimensional image, but when you look at it cross-sectionally, this implant may well get close to or perforate that cortical plate if you're not looking carefully three-dimensionally. So one of the neat things you can do on the software here is to virtually place the implant three-dimensionally. You can pick whichever brand, whichever size of implant you're planning on using. You kind of click and drag that image over into your X-ray image. Look at this in three dimensions. You need to adjust it a little bit. You move it a little bit. You move it a little bit in this dimension, that dimension, rotate it, whatever you need to do till you know, now I can see in three dimension what the bone looks like around there, and I know this is the best place for my implant. Then what you can do, and you can, again, you can choose different types and different sizes, then you can sort of marry this information to a surgical stent, a surgical guide that will, by taking there's different ways of doing it on different systems, but you can take an impression, have a little mouthpiece now that fits over while you take an image, and you can exactly duplicate exactly where this implant is onto a surgical guide template that can be made for you, especially if you have on the Sirona system, it's nicely married to the CEREC system, and a neat way to build a little surgical guide that now will exactly guide your placement of the post hole exactly where you placed it virtually on the screen. Here's one that didn't have such good planning. Obviously, this is the kind of thing you're trying to avoid. So the cone beam image plus the surgical guides leads to more successful outcomes. The more diagnostic information that's available may also mean more responsibility. This is, I think, what the concern is in where did I say the problem was in Canada? In Ottawa. They won't let dentists have one in their own offices. If you are taking an image that shows a whole lot more information, you may then be medical legally responsible for knowing that information, and if you miss something, is it, can you be in trouble? So that's why a lot of people will send their images for confirmation to a radiology service like beam readers. Is it expensive? If you're talking about buying, I mean, you have to make the decision, do I want to buy one or do I want to just refer this to somewhere who can take it for me? If you're looking at buying one, is it expensive? The answer is yes and no. Yes, they're expensive. Again, I got some of this information from that clinician's report article. The cost may be somewhere between $100,000, $170,000. I don't know how this translates to monthly if you're leasing it or if you're buying it over time. But you have to, figure out those numbers versus how many images do you think you would take a month, and what are you going to charge for them? Typical charges are going to be somewhere between $100 and $400 per image. This is what dentists typically are charging around the country, and you have to decide if these numbers make sense to own it or to find some place that uses them. If you decide you want to own it, you certainly need to be charging an appropriate fee. You may want to defray costs by offering to take some images for colleagues. That can get some of your help you with your monthly payments. Again, there may be the question of, if you take this image for Dr. Jones, who's legally responsible for the information on the image, Dr. Jones or you, the one that took it? I don't know the answer there. Maybe our attorneys can give us some answers there, but I've heard that this question gets brought up. You're certainly going to get increased dentistry from the enhanced diagnostic ability. So if you think in terms of the dollar payback that you're going to get it in dentistry and not just in the fee for the images themselves. That's about it. We have time for a few questions if you want, and then we can do more questions at the forum. Yes?
Yes, I'm just curious about cavitation and what your experience is with helping
Yes, so he asked about cavitations and what's been my experience. Again, I'm a little different from a lot of you. I don't do cavitation surgery. I just don't like to. But there's people in our area that are good at doing that. And what I'm seeing is when it even looks suspicious on a cone beam x-rays, it's definitely there. I mean, you can see some real obvious things on a cone beam that you won't see on a panoramic or a flat image. And sometimes it's a little bit iffy looking at that. There's also ways on this unit and maybe on other brands as well where you can manipulate the bone and get reading on bone density, and that helps to evaluate those areas. But it seems, from what I've seen so far, when it looks suspicious on the cone beam x-rays, it's definitely there, and it's definitely bigger than what you see on the image.
And do they always kind of appear below the cortex,
Sometimes you don't even see a cortex. You can see, they're just medullary bone there. And he asked if does it always appear just below the cortex. Yeah, not always. I mean, sometimes it can be down deeper. Sometimes it may be, you just drop through that cortex, and right below that paper-thin cortex, there's this big void. Sometimes it may be, the remnant of a little tiny root fragment that's way down deeper, and maybe there's some fairly solid bone above that. But again, you can get a sense of where that defect is three-dimensionally, and you know sort of where to aim when you're starting the surgery. In the back. Sure. He's asking about, just some other ways of manipulating this image. For example, if we want to look at this anterior root canal here, and we'll click on the window there. This image doesn't look so great. We can see this cross-sectional view. This image is a little harder to see. You can see the little crosshairs here. I can slide and re-angle this view. Notice on the lower middle view, now I've got that lined up along the long axis of this tooth. Now when we look at this screen on the left, we can see this image more clearly. If I hadn't lined this up this way, this image looks kind of distorted. Is this the question you were asking? Yeah, so probably different brands have different ways of manipulating. This is a neat way that this really helps to get a more clear, straight-on view of the tooth and not foreshortened, and you can kind of come from whatever angle that you want. Hard for me to see. Can we turn lights back up maybe? Hard for me to see people's hands. Any other questions? Holler if you do, because I can't see you. Okay. Well, thanks for coming. I hope this has been helpful. And again, this just sort of scratches the surface. You really should take a full-blown, thorough course on radiology with this.